Thank you. I now recognize Ms. Chu.
It was just less than 3 weeks ago that President Trump and Republicans passed the single largest rollback of health care in our country's history in the big ugly bill. $500 billion in Medicare cuts, $1.5 trillion in total health care cuts, the largest cut to Medicaid ever, and a $5 trillion deficit increase, all disguised as an effort to root out waste, fraud, and abuse. The result? More than 15 million Americans will lose their health coverage. And some of those people won't lose coverage because they made too much money or no longer qualify. They'll lose it because they missed a paperwork deadline. That's the truth behind Medicaid paperwork requirements. Medicaid is not a cash assistance program, it's health insurance. No one is getting a check in the mail. They're getting a doctor's visit, a prescription filled, or help paying for a nursing home stay. So when Republicans claim they're going after fraud, what they're really doing is kicking people off coverage for failing to navigate red tape and freeing up money to pay for tax cuts for billionaires. And meanwhile, there is real waste, fraud, and abuse happening in Medicare Advantage. We've seen rampant upcoding that is submitting higher reimbursements for codes than the services actually received. We see inflated risk scores of enrollees. We see opaque AI systems denying medically necessary care and a complete lack of transparency. GAO, HHS, OIG, and MedPAC have all raised the alarm bells. So, Dr. Fiedler, I'd like to ask you, can you explain why Medicaid work requirements don't actually detect fraud and how, by contrast, Medicare Advantage is raking in billions in improper payments with virtually no accountability? Why should Congress let multi-billion-dollar insurers game the Medicare system while punishing low-income families who are just trying to stay healthy?
So thank you for the question. So no, as you said, Medicaid work requirements are not a policy targeted at fraud. They remove eligibility from some low-income adults, for example, someone who's recently lost their job and is looking for work. And then, as you alluded to, they cause many people who are in compliance with the policy, they're working, they're in school, they have a health condition that would exempt them from the policy, to lose coverage because they can't document that they fall into one of those categories. And so, we know that that does save the government money because now fewer people are insured, but that's at the cost of worsening access to care, financial security, and health outcomes for the people who are now uninsured. On the Medicare Advantage side, we have clear evidence that we're paying Medicare Advantage plans tens of billions of dollars a year that we're not supposed to be paying them under the law. And we also have evidence that those additional payments aren't generating commensurate value for beneficiaries. So I think the trade-offs involved in these two policies are quite different.
Now, when Medicare Advantage was first created, Dr. Fiedler, it was sold as a way to give seniors more choices, better coordinated care, and lower costs. But after 2 decades, that promise hasn't held up. Instead of saving money, the federal government is now paying 20% more per beneficiary in MA than in traditional Medicare, to the tune of $84 billion in overpayments this year. So we know that 50% of every additional dollar paid to MA plans actually benefits patients, and that's just 50%. The rest goes towards profit, marketing, and prior authorization systems that increasingly rely on artificial intelligence. We've seen AI tools deny chemotherapy, rehab, and post-acute care, not because the care wasn't medically necessary, but because the algorithm said no. That's why I'm preparing to introduce legislation that would require transparency in how MA plans use AI, ensure that any AI system complies with traditional Medicare coverage standards, and mandate physician review before any adverse determination is issued. It would also direct CMS to audit AI algorithms and evaluate their impact on patient access. Dr. Fiedler, can you talk about the necessity for federal guardrails on these AI technologies?
So I think just as there's been a lot of discussion about the need for appropriate oversight of prior authorization generally, I think there's an important need to make sure that that framework extends to AI and the other new technologies that we have coming down the pipeline. In some cases, that'll happen automatically, but in some cases, that's going to require policy action to make sure that happens. Obviously, to the extent that doesn't happen, this sort of, talking about, we had some discussion about striking the balance of good prior auth, but excessive and avoiding excessive prior auth. And I think we need to strike the same balance with respect to the use of AI.
Thank you. I yield back.